All right, welcome back to Basically ALS. We're going to be talking about blood today. Should be pretty cool. Have a couple of special guests. So you know me and Wade, and Casey's been on a couple times. Yes. But you want to introduce yourself and give a little bit about your background?
Yeah, so I'm Donald. I founded a company here in Boise. We're developing a battery-powered cooler. I spent about 13 years as an Army medic, kind of doing all that fun stuff. And now I'm here. So
cool. Right on. Right on. And then Casey, you fly, so you have experience with blood products, right. Flying. Wade and I have never used blood products, so we're gonna learn more than we're gonna say here, which will be kind of fun to talk about it. So, so getting into blood in EMS, I think first thing we need to talk about is what we carry or what is carried in EMS as far as blood products. So, what have you guys carried in the military and in your your flight job? Like whole blood products, or what do you guys have out there?
Yeah. So currently, my company, we carry 2 units of blood, 1 O pos, 1 O negative, and then 1 unit of plasma. That's about all we have for, per flight.
Okay.
Yeah.
How about military? Did you carry blood?
I personally didn't, but I have buddies that have, and they always carry whole blood. Okay. Usually low titer, O negative, whole blood.
Okay. And my apologies, it was packed red blood cells, not whole blood.
Okay.
Yeah, we carry PRBCs.
Okay, so no whole blood for you guys.
Not whole blood for us.
Okay, but military is whole blood?
Yeah.
Yeah. Okay. So you're saying packed red blood cells, and then was it platelets or plasma?
Plasma.
Yeah. So just kind of fluid replacement essentially for you
Volume
guys.
Replacement.
Yeah. And then whole blood as well. Platelets can also be carried, but it doesn't sound like that's anything you guys have carried. Right.
I've never really messed around with platelets before. Maybe once or twice, but couldn't remember. Don't have enough knowledge to be able to really speak on it significantly.
My research was showing that it's mostly in hospital use, just because of there's so many cascading factors they have to consider. And in EMS, it's hard to maintain that.
And that makes a lot of sense. Yeah.
Usually surgeries, things like that.
Right.
Yeah. So kind of functions of each of those. So packed red blood cells, that kind of seems pretty straightforward, right? You're going to have that oxygen carrying capability because that's what red blood cells do, right? Plasma, I think like just volume depletion replacement essentially is what we were talking about. So again, makes sense, kind of like a isotonic solution, just better, right?
Just better and with a little bit more of a actual human body composition to it. Your packed red blood cells totally just for oxygen carrying capacity, no real volume capacity there at all. So if you got a soft blood pressure and you don't want to dilute them even more with an isotonic, then we would give some plasma.
So is there anything specifically you're looking for those RBCs versus plasma? Is it like, SpO2 numbers or any objective criteria?
Pretty, I would say run-of-the-mill guideline would be hemoglobin of 7 or under. That's kind of the go-to number.
Okay. And that's something you guys have a little quick stat kind of thing you can check out there?
We are quite lucky. Yeah, we have an iStat machine where we can take labs in the field. Okay. Not very many, even flight people have those. Definitely feel lucky about that, but it does make it quite a bit easier. And at the same time, I'll say it's also not super hard to figure out if somebody needs a unit, right? Depending on mechanism, depending on presentation, vitals, stuff like that. So,
okay. Do you guys carry that just due to because you fly up in Alaska, you're very rural. Right. Is that why you guys carry and have the capability to do labs? Is that mostly based off of your demographic in your area?
I would say that, and I don't even know if rural is the right word, but maybe our transports are long enough where you don't necessarily, you have a condensed toolkit and, you don't have the option to divert to the next hospital as easily. Rural is definitely a part of it. I don't know if we are carrying it just for the sake of us being rural. I think it's more the longer transport times.
Okay. Yeah, and that makes sense.
Yeah.
That makes sense.
Going back to your military experience stuff, so you said some of your buddies would carry blood. Did you carry any blood products at all?
No, I never did.
Okay.
It wasn't feasible for us for our mission sets where we would need to have that capability for like 24 to 48 hours. And at the time, the best we could do is 12.
Gotcha.
So it's like, I got blood for 12 hours and I'm just going to throw it out because it's not usable anymore.
Which like
Right.
hurts you in your soul.
Yeah.
To, like get rid of blood.
So like, do we take blood away from like a major trauma center or a medical treatment facility for a maybe for a 12-hour window, or just risk it and hopefully IV fluids will do enough and we get a bird there quick enough?
Interesting.
So platelets, obviously it's going to be higher risk, right? If we're just dumping platelets, I'd imagine, for blood clots. Is that why that's not as common out there? What do you guys know why platelets are kind of it seems like they're the least used?
Yeah, there's a lot of cascading effects that come in when you give platelets. And if you don't have the capability, like if you're out in the middle of Alaska and you push platelets and some dude has a stroke because of it, it's like, oh crap, now we got to push these other drugs. Hopefully we don't cause more issues and get them to that medical facility.
Right.
So that the benefits to risk is higher for platelets, right?
Right.
Yeah.
It also looks like platelets have the shortest shelf life comparatively amongst all of them too. So I could see the management on that side too being hard.
Right. Totally.
Whole blood just seems like it would probably be the best to carry, but probably the hardest to get. Does that sound about right? I mean, it's got all the components that we're looking for.
Yeah, your whole blood is like the holy grail.
Yeah.
Everything you need. Depending on the agencies that do carry blood, civilian side, usually they carry O positive. Something like 85% of the population is a RH positive. Military, we focus on O negative, specifically the low titer O negative, to minimize any interactions with the patient.
Which thankfully seems, in my looking at this, it seems like it's a pretty low risk regardless for the interactions. It doesn't seem like, at least civilian side, like it really, a very, very minor percentage, at least from the studies I was looking at.
Yeah, I mean, you can get the wrong blood type once and you'll be fine. Like I'm O negative, I can get O positive once, but that second time, not so great for me.
Yeah, usually about roughly 7% of people have a reaction to the O-pos, or the O-neg. We keep the O-neg mainly for women of pregnant bearing age. Whole other topic of conversation as far as RH factor and why we try to do that, but the vast majority of people are totally fine, especially just once getting the wrong RH factor and getting O-pos.
Yeah, and especially I feel like in this use case, like the risk is pretty high of not getting it. So for the low likelihood of having major complications, like you're not giving it just because somebody stubbed their toe. Like this is a life-threatening injury that's occurring that we need to get blood for. Right. So we're okay with that risk a little bit. Yeah. Are there any like synthetic products we can use? I didn't follow up on it. I remember a couple of years ago hearing about like synthetic red blood cells maybe or something. Is there anything out there currently?
They're trying. There's a new company. They're doing something with like ultra deep seawater and some weird super chemically stuff with that they're actually having pretty good, not red blood cell replacement, but has that increased oxygen carrying capacity that you don't have with saline.
Okay.
So might here in a couple of years maybe, but it's they've been trying for years and haven't quite cracked that code yet.
Nothing commercially out there yet.
No.
Right. And as soon as they do crack it, it's going to take another 10 to 15 years for the FDA to approve it and for it to trickle down, right? The military will get it first, for sure.
It'll be the test gun dummies.
Yep, exactly. There's some basically freeze-dried plasma out there. I actually just learned that really the only people that are doing it are the French currently. I see quite a bit of reading material on it, but again, it hasn't just trickled down yet through the marshes of approval.
What's the benefit of freeze-dried plasma? Is it just shelf life and all of that, or is there anything different? That
shelf life, logistics. I don't have to keep it as cold. It's a lot more forgiving than whole blood, right. And you just reconstitute it and push it in, and you're good to go.
Okay.
Yeah, my research was saying room temp storage on that, so super manageable. Right. Leave it alone for a while. It sounds like too.
Yeah, comparatively to everything else. So shelf life for blood products, do you guys have any idea on those numbers?
Your whole blood depends on agency and what study you're looking at. It's usually 28 to 35 days for a bag of whole blood.
Okay.
Is that temperature dependent?
Yes.
Okay.
So if it goes outside of temperature, which is 1 to 6 degrees Celsius for more than 30 minutes, then it's bad.
Gotcha.
Throw it out.
So very temperature dependent.
Yeah.
Yeah.
Check.
If it gets too cold, you have to throw it out. If it gets too hot, you have to throw it out.
Yeah.
So it's
Got to find the sweet spot, the Goldilocks of it, huh?
yep.
Yeah. Our plasma, we have a kind of a rotating deal with the Blood Bank of Alaska. So our plasma, we would resend it back every month. With our packed red blood cells, we send it back every 2 weeks.
Okay.
And that's, mainly there's a little bit of cushion there as far as shelf life goes and expiration, as long as it stays within temp. But that's just to make just extra sure that we're nowhere near the possibility of having out of date or bad blood.
Okay. So essentially you guys kind of get first pass at it when it's fresh. If you don't use it in that time, you send it back so it will get used.
Hopefully.
Otherwise without it just being tossed,
Right.
essentially, because it's such a precious resource.
Right.
Interesting. Okay. So historically, right, we've always used saline. What is the downside of saline that's being fixed by using blood and blood products in the field?
Your saline's great to rehydrate, but it's like I push a liter of saline into a body. It's only there for, I think it's like 4 hours or something like that before it starts going to that interstitial fluids. So you don't really get a huge increase in pressure, and you don't have the oxygen carrying capability. So you're basically turning blood into Kool-Aid and calling it juice and hoping it works the same.
Yeah.
Yeah. And just to go a little further with that, especially, probably going to start a big debate here, but, sodium chloride, saline, what we would give the kind of normal go-to isotonic, with the amount that some people are dumping into these heavily bleeding patients, we are really kind of metabolically messing them up. You start to get some like chloremic acidosis on ion gap. It's harder to recognize. It's harder to fix. It's just not. Again, I don't want to start a huge debate here, but in that setting where you don't have any blood, LR is probably a better isotonic to go to. It's still not great, but again, people are seeing these super soft blood pressures and they're seeing all this bleeding and they just want to help, and so they're dumping liters and liters of saline in, and it's probably on the verge of hurting more than helping.
Yeah. And that's
go ahead. Yeah. Does that go with like, so the amount that we're pushing, right, is going to be the big one, but then time of transport. So if we have like a major bleeder and we're like, I don't know, an hour and a half transport by ground out, and we're just going to be dumping fluid, we're just diluting down the chain, if I'm reading correctly.
Just turning Kool-Aid. Yep.
Okay. So we're losing oxygen capability, clotting capability. So in the end of the day, you're not doing a whole lot of good.
Right. And that's exactly it, right? You're reducing oxygen carrying capacity and you're reducing clotting factors.
Gotcha.
There was one fluid the military started using kind of as we were learning that saline and LR weren't cutting it, called Hextend or Hexastarch into saline, essentially. So like a 500 mil bag will do about what 7 liters of NS will do for the body. So it pulls in that interstitial fluid through osmotic pressures to increase those pressures. You get some increase in oxygen carrying capacity, but not much. But I mean, even with that, we were having issues of people pushing that and blowing clots out of people.
Gotcha.
Just too much pressure. So it's a lot more like saline. I could pretty much just spike it, call it good. And if I do overpressure you, it'll be gone pretty quickly.
Gotcha.
Hextend's a lot longer lasting, so you have to monitor that a lot more.
Interesting.
I remember talking to a previous medical director that we all shared at one point, and we were actually talking about this Hextend stuff, and he was actually really excited about it, but what made him nervous was that's kind of starting to go outside the realm of isotonic and get into hypotonic and hypertonic. And, at the time with the stereotype of medics being trained and not educated, that made him nervous to start digging a little deeper into the physiology of hypertonic and hypotonic fluids.
I think that's something we don't, like going through the medic process and being a medic, that a lot of it's training, but yeah, we do have that depth of knowledge. It's just one of those things that starts to fall off, right. And especially when it's something that's like salion's tried and true, quote unquote, right? So we've been doing this forever. So that swap to a different solution type, I can see the problem. I can definitely see the thought process there with him.
Yeah.
And so is this where the permissive hypotension protocols are coming in, where with places that cannot carry blood or blood products? Is this to kind of the benefit of the permissive hypotension, keep enough pressure to feed the brain and the heart and the organs and everything without dumping so much unnecessary, useless fluids in that we're not diluting the blood down, essentially, right?
Right. And permissive hypotension goes for blood replacement as well, right? Especially if it's if you're bleeding from an area that you can't stop, that needs a surgeon, whether it be GI or junctional or whatever, something that you can't put a tourniquet on or you can't pack or anything like that, you're still shooting for that permissive hypotension, right? That MAP of 60 to 65, the systolic of 90, however you want to look at it. If you can't stop it, you still run the risk of continuing to bleed if you raise that pressure too high. It's just going to blow clots out.
Interesting. Okay. Yeah. So when you say blow clots out, you mean like newly formed clots? Right. You're just going to overpressurize the system.
Too
much pressure. Yeah.
You lose the clot.
Okay.
Yep.
So bleeding continues.
Yep.
Yeah.
90 is kind of that sweet spot to keep oxygenation for the brain, your organs, and all that other stuff, keep everything alive, but without having enough or so much pressure that these newer clots are still weak already.
Right.
You're not just blowing them out and creating another fountain.
100%. Yep.
So have you seen from the military side to the civilian side, have you seen any stuff that in your military experience you were kind of on the forefront of learning start to transition itself here? Is a lot of this like, oh yeah, these guys just learned this 5 years ago. I knew this 15 years ago. Have you kind of seen
the big one, like for us, was the bleeding control. I mean, tourniquets was a huge one. I mean, that was taboo. Is like you might as well go slap your grandma across the face before you put a tourniquet on anyone in the civilian side. And military, we were like, oh yeah, throw a tourniquet on it, and then we'll convert it in the field, and if we can, we'll loosen the tourniquet and change to a pressure dressing. I don't know if civilian EMS is doing conversions.
On paper, we can. Again, that's a little bit more of a rural and a longer transport type conversation. The crux that we're running into is a lot of these rural agencies don't quite have the education or the scope to do a lot of these things that we're talking about. But yeah, on paper, a paramedic can transition a tourniquet device.
And then another one was just like the use of Hextend. We were using that, and like I was working in the ER down in Pocatello, and we had a guy who got a gunshot wound to the chest, and they were just pumping him full of LR. And I was like, why are you guys in ambulance not carrying Hextend? And the doctor's like, Hextend. And I'm like, oh, you have no idea what that is, do you? All right, well, there's some education, man. He's like, yeah, I think we'll just stick with Hextend, with the LR. I'm like, I mean, you're the MD, man, not me. I'm just
Yeah. I mean, how much of that though is education and then just availability too? I'm sure that's a big thing, especially Pocatello, Idaho.
Yeah.
It's not.
We're not a major trauma center
LA
by
trauma
any
center
means.
or something that probably would get access to this stuff first.
Right.
Or even just practicality of converting in the field. Like when you have a 10-minute transport, I'm just going to leave it, Yeah. That doesn't make any sense to me or for us to pull that off anyway.
Right.
At least in that, like I said, short transport time.
And on top of that, you have training complications and barriers to run into, right? We've all seen it before, that it's just kind of human nature that you, rather than train up, you train to the lowest common denominator, which is unfortunate. But, the reality is the training barriers still exist. You still have to get this new product, and you still have to train everybody up to competency, and that takes time. It takes money.
You're trying to start another fight, aren't you? Here, that's a whole other thing with, especially when we're talking about this stuff on a national scope of like, as we bring these new products or these new things, like everyone has to be trained to that level,
right?
And I think a lot of people have really good intentions about what they would like to see in EMS without maybe some reality checks on, like, we're not just talking about people in major cities with really good education programs and colleges. Right. We're talking about Salmon, Idaho, or somewhere in the middle of nowhere in Alaska that you need to train people to be able to do these high risk, possibly high reward, but high risk procedures and all of this. And so maybe it's just not going to get out there, right? Because we just don't have the capability to train everybody to those levels. And
to the point of his story, the docs sometimes even need training, right? The medical directors of these programs still need education on this stuff.
Yeah. And usually they're trying to run the ER. They're maybe the one physician in that city or that town, and they have to just make sure that town's not dying, right? And at the same time, they still need to be putting in that work to learn these new things and all that. So it's a big ask, especially in somewhere like the U.S. that is so huge and has so many just open areas that we just don't have people there, and then you get into how are you going to pay those people too, right? It's a whole cascade of issues that can be really hard.
And that's the downside is, having whole blood is more important in those super rural communities than it is in, downtown Boise or cool. Like, it is important here still where I could have a 20, 30 minute transport time via ground with traffic. But when you have an hour transport time and it's going to take you 30 minutes for the EMS personnel to even get there before a bird can even go.
Right.
Like every 1 minute of a delayed blood transfusion after traumatic injury is a 1% decrease in survivability over 24 hours and 30 days.
Yeah.
So that starts adding up really quickly.
Right.
Yeah. Yeah, and that was really the one thing I could find in looking at studies that were kind of negative about, or saying blood maybe is not super necessary, is mostly just urban areas with short transport times. It's not really necessary then. And that would be the people who have access to it, which is just a weird kind of dichotomy of it, unfortunately. So studies wise, obviously we're not just going to go dissect studies right now, but do you guys have anything, people listening right now that are interested in this? Are there anything that you guys have looked or heard about that you're like, hey, that was really cool, that had really good information, that maybe just resources we could share for people?
Yeah, there's a ton of great resources and studies done by the military, the joint trauma systems. It's free to access. You have studies, they look at pre-hospital blood use, military, civilian side, indications, contraindications, risks, benefits, and put a lot of that stuff out there that's easy to get, easy to digest. Great things if you guys are like, hey, we need blood in our agency, you can pull those articles all day long and give them to your medical director, say, hey man, this is why we need blood.
Then that's sometimes the push is the field level providers going to the medical directors, be like, look at all this. I did your work for you a little bit. Look at all these things, and this is why we should at least try to pursue it for sure.
GEMS and JAMA are all also chock full of good studies, good meta-analyses. Those are also two good resources.
Yeah, it looked like the Pamper paper seems like it's a pretty
Pamper
big one.
Was a good one.
Pre-hospital air medical plasma was one that I was looking at. And then NAEMSP, so the National Association of EMS Physicians, had a kind of a really good meta-analysis that I think I mentioned already, but I
think that one was published actually in GEMS and JAMA too.
Was it?
Yeah.
Yeah, I think I found it through their website, but I know that's a recent one too. I think that was earlier this year, and it seemed very comprehensive. And they were very positive on blood and blood products usage in the realm of EMS with that study. So let's get down to the nitty gritty. Blood products, the why and the when, right? So especially you guys maybe having, or at least Casey having used blood products, what are your protocols? When are you going to use it? Kind of what are your use cases for using blood and blood products?
Yeah. So every person that needs blood, unless they're a female of pregnant bearing age, they're getting O positive packed red blood cells. We have a little bit of, for lack of a better term, we'll call it freedom in kind of assessing the need for, volume replacement, with plasma versus need for oxygen. We kind of have medical director that kind of trusts us to look at that. And if we can't get a hold of them because we're in super rural Alaska or we're up in the air and the sat phone's not working, we have a little bit of freedom there to kind of decide which one they need. Again, that hemoglobin of 7 or under is kind of a standard guideline for everybody. And then also just, looking at the big picture, if you have a trauma victim and the mechanism is significant enough, it can take extra time just to get that lab and that ISTAT set up and everything, the blood draw. So we're kind of given a little bit extra freedom there too to kind of pull the trigger if we think it's needed.
So for you, when it comes to, because obviously I know why you're giving blood in the battlefield area, right? But like, what was your discrepancy for like, oh, this is going to be severe enough where we should get blood, at least somebody with blood closer?
The big things that we were looking at, we don't have the fancy iStats out there with us. Too much weight. I ain't carrying that.
There.
So we look at radial pulses.
Gotcha.
So altered mental status, loss of radial pulses, and a mechanism of injury that would suggest either internal or external hemorrhage. Then we would give blood to maintain that radial pulse. Once the radial pulse is back, we would cut the blood off. Once it comes back, or once we lose that radial pulse again, we kind of titrate it to try and find that happy medium where we're not overpressuring you, but you're not under pressure. We can kind of sit right about that 90.
Nice. That's good assessment base, because I know you lose the radial around 90 systolic. So that's interesting that, I mean, it's a duh thing, but it's one of those things that's so simple. You think you need the iStat and all these fancy things. It's like, no, just feel a pulse.
And you really don't. Yeah. And there's going to be some people undoubtedly who'll be like, that's not backed up by science. And that's not, that's not accurate. This and this different factor. It's just a tool among many to use to get a bigger picture, right? It doesn't have to be, yes, once you lose your radial, you're under 90, period, black and white. No, that's not how it works. But it's a good tool to use to help assess the biggest picture.
Especially like in like a combat situation where like you just need something, and even civilian EMS, like you're on the side of a freeway and you have 3 patients. That's a real quick, easy thing. I can check that and have a good guideline.
Right.
The NAEMSP study, they suggested, and kind of goes right along with this. So use when you have a systolic below 90, the shock index, which is the heart rate divided by the systolic blood pressure, which I had never heard that before. But once I saw that, I was like, man, that's so simple.
Yeah.
And it's such a good thing, especially like EMT levels that don't really understand really well that relationship between like tachycardia and hypotension and compensated, decompensated shock. But that's greater than 1. They recommend it, and I was like, oh yeah, that's so simple. I really like that. Right. Lactate over 4, amputation, limb injury with external blood loss requiring tourniquets, penetrating injury, the neck, chest, abdomen, pelvis, and then positive ultrasound for intraperitoneal fluid. So for the most part, like they recommend pretty basic, easy things for us to recognize, right? Like systolic below 90, heart rate higher than systolic blood pressure for the trauma score. And then the bad things like stabbings and stuff to the core, right? Or if you put a tourniquet on, it's really pretty basic of when they recommend to use the blood products if you have them.
The downside of it, we're so new into blood being carried by civilian EMS. Like the military, our focus is trauma. People getting shot, blown up, not a great day. Civilian EMS, there's agencies that they have pulled in their protocols for even like major concussions, giving whole blood products. And they're like, we have better outcomes. Why? We don't know, but we seem to be having better outcomes. They're like, okay, well, half the country still can't get blood. And you guys are like, just give it to everyone. See what happens.
I mean, at the same time, though, that's how you figure out what it works in. Yeah. You just kind of got to throw it out there. So,
and blood seems to be use it or lose it. So
that's true.
That's exactly
might as well.
Yeah. Casey, for you guys, obviously the trauma stuff's easy, right? Trauma, hemorrhagic shock, easy peasy, we know. How about medical cases? Do you guys have protocols for OB patients or possible GI bleeds, that kind of thing?
Yeah, all the above. And again, that's where, like you said, the trauma cases they're a little bit more easy to, figure out if somebody needs blood without the use of labs and blood work. Some of these medical cases, that's where it kind of gets a little bit more sketchy, and you might need to do that little bit more thorough check into the blood work. So yeah, all of the above. OB stuff, GI bleeds, esophageal varices are a big one. Yeah, all of the above.
Have you seen, is there I'd imagine like a higher prevalence of you using this for traumatic cases than for medical cases, or is it pretty even? What has your experience been?
Actually pretty even. Maybe even, maybe even a smidge more on the medical side with, if you're in an area with a demographic of a ETOH issue, an alcohol issue, things like those esophageal varices and GI bleeds, those are a lot more prevalent than, especially when those places don't have traditional traffic systems that we do. They're just riding around on snowmobiles and four-wheelers. There's actually not as much trauma. When there is, it's good trauma, but there's usually not as much.
Yeah, that makes sense.
So you actually get maybe a little bit more on the medical side for blood giving than the trauma side.
Okay. That's interesting perspective. I never would have, if they're not hitting each other in cars and all of that, maybe running into a moose here and there. Less likely for the more normal kind of stuff. How about peds? Do you guys give blood products to peds? Are there any stipulations on that?
There's peds specific protocols, especially when it comes to the volume, right? These guys are so much more sensitive to volume than we are. And we actually, our clinical manager, I haven't really talked to our medical directors about this yet, but our clinical manager, he is big on blood to pediatrics, right? Because they have so much less reserve and compensation capacity, right? They just go heart rate, balls to the wall until they can't anymore. So he is a big proponent of blood to these pediatric populations.
Is there any difference in what kind of products you give, or is same across the board?
Same across the board.
Just different volumes.
As far as our protocols, it's just across the board.
Cool. That makes sense too, because peds are breathers historically, right? So getting them those especially packed red blood cells, let's increase oxygenation. That seems like you're fixing a lot of issues with one intervention.
Right.
Yeah. Well, because they're so respiratory dependent, it seems like maybe a little bit more important than for adults to get that red blood cell replacement if they are bleeding out. So how about challenges with blood products in EMS? What has your guys' experience been of the challenges?
Temperature sucks. Huge logistical constraint on agencies, even outside of an ambulance, even hospitals, small clinics, rural clinics, things like that. It's a nightmare to take care of. You got to have your logs, make sure your temperature is maintained appropriately. If it goes outside of that, you have to have alarm systems in place. And so it could be a real nightmare for agencies to actually have blood, carry blood, and be able to utilize that in both a field setting and a clinical setting.
Yeah. That goes for heat and too cold. Right? They can get too hot and too cold.
Yeah. I'd imagine that would be a real concern for you guys, I'd imagine, right?
You can essentially freezer burn blood, and it's bad. So we have very robust mobile blood kits that protect both cold and hot.
How about access to blood? Is that you guys? It sounds like have a good thing with the Alaska Blood Bank, and so maybe you don't know other systems very well, but have you guys heard anything anecdotally or seen anything? What are the real challenges for that? And do you guys know of any support nationally for systems getting any blood?
I know there's a grant. Pull it up just so I don't misquote this because I would hate to do that live on air.
We've already started enough fights today. Let's not start more.
Controversial day.
So there's currently the Centers for Medicare and Medicaid Services just announced a Rural Health Transformation Program. It's a $50 billion initiative to strengthen healthcare in rural America. A major opportunity for states to secure funding that can directly benefit rural communities, especially in critical areas like emergency preparedness, pre-hospital blood programs, and cold chain logistics.
Cool.
So there's a large grant program that all these agencies, states have access to help push that blood program out into those rural communities to cover the training, the equipment, all that stuff.
And so obviously training would be another challenge, right? We talked about this a little bit before about training people on the equipment and the usage of blood,
right?
Especially more rural areas. Maybe they don't have those responders that have that experience of just running calls after calls, right? Like it's that weird thing of, you really need to be on your game when you're out there. You just don't see enough to be on your game sometimes.
Exactly.
Which
At
is
high acuity, low frequency.
Right.
yeah, that's already the case in a busy system.
Right.
That we, unless you're like Medic 1 where you're intubating all the time. Like how many times do you I would intubate a couple times a year, right? Realistically, and working in a fairly busy system. I wasn't super aggressive about it. I probably could have justified more intubations, but 3 or 4 a year probably was pretty realistic. And that's in Boise, Idaho, which is not small. It's not big, but it's still 250,000 population that we're serving in the county, right? Like, yeah. So these places that maybe would see this once every other year, right? Like it's hard to be trained at that level.
It is. It really is.
So you talked a little bit about, the storage capabilities, and this is your bread and butter, right? So,
Yeah.
Tell us a little bit about what you guys have been doing, because you have a product that you're working on for that. What challenges are you guys trying to solve, and how are you solving those challenges?
Yeah, so the big challenge we couldn't carry blood for long enough. There wasn't anything on the market that would allow us to do that. So that was my main goal is how can we get blood stable for longer, where it's reliable. I can cold chains of custodies and is working. There's no questions on the integrity of the blood, but then also size. I was a ground medic. I had a vehicle. Sometimes we were dismounted, moving around. I don't want to carry around a giant Yeti cooler. That's heavy. It's bulky. I can't do anything other than carry that cooler. So it's just kind of pointless. And that's kind of tied over into civilian EMS, where these agencies we want to carry blood, but we don't have room in our rig to throw a giant cooler. We have to lose some capability for this capability that we may or may not ever use. So that's where I was we can carry 4 units of blood inside our cooler. It's small, it's compact. You could put it into an ambulance where you can power it up to the vehicle itself. You're not worried about that. It's logging that data real time. So there's no question about is the blood still good? We have another sensor in there we got to pull the data from. So we're still working on the software applications of that, so you can pull it to your phone or your computer or wherever to track that real time. But our main goal is just make it more portable, more feasible for agencies to be able to utilize blood in the field. Okay.
And for your product, how much product can you carry in there?
So this is that's it, right? That's our prototype right now. So this will hold 4 units of blood, and then we just use a DeWalt battery there on the bottom to extend that out, and we're about 48 hours with the large DeWalt battery and with the 4 units.
Cool.
Which that's what our mobile kit does too, 48 hours.
Okay.
Yep.
Size-wise, is yours pretty similar, bigger? From looking around, it seems like this is a lot smaller than anything that we were able to see.
Ours is, usable space. It's probably about the same, actually. We only carry the 2 PRBCs and the 1 plasma. But yeah, you could probably fit, I don't know, 2 to 3 more units in there. Yeah, it's about the same.
Okay.
But you're gunning for whole blood, right? That's what.
Yeah, that's the main focus. But then also with ours, the way we do the cooling, we can warm as well.
Nice.
So if you're in an Arctic environment like up in Alaska, where you're worried about it getting too cold, our device can go, temperature is dropping. So we can regulate that temperature within the thousandths of a degree Celsius.
That's pretty cool.
So we can be hey, we dropped it, 4.9 degrees Celsius. Our target's at 5. Cool. Let's flip that over, start heating it to maintain that that temperature.
So you find that nice PEMDAS, lack of a better, find that middle ground there.
So that would be just to keep it within that 1 to 6 Celsius range. That's not necessarily, the warming feature wouldn't necessarily be to heat it up for administration.
You could do it as well. When you have 4 units of blood in there, it's am I using all of it? Or
right. Yeah.
But even then, Baton Rouge, their EMS agency, they've been pushing whole blood without warming it and have not been seeing any negative outcomes. My physics brain says there's issues with that, but
hypothermia being part of that trauma triangle.
But at the same time, it's such a slow, you're not slamming these bags of blood in there and rapidly dropping that temp. So it's, you can adjust for that, throw Peter on, things like that to the body to adjust for hypothermia. So there might be some changes coming down. I know they're doing a study right now on that.
Sure.
To whether or not they need to warm blood before administering it. So that'll be interesting to see what comes out of that.
Totally.
Is that within your guys' protocols now to warm it?
Yeah.
Yeah. Do you guys just warm it with air? How do you guys warm it?
Yeah. So we have a battery-driven coil-infused administration line. It's just your regular micro drip set, but it's got a coil in it that we hook up to a battery, and it heats it as it's going in.
Interesting. That's cool.
Those are the thermal angels?
No, these are they're made by NAR.
Okay. I know what you're talking about.
Yeah.
So for your guys' product, weight-wise, do you know what the weight is expected to be?
We're expecting right about 12 pounds with 4 units of blood.
That's pretty good.
That's good.
Right now we're 17.
Oh, okay.
So
That's stellar. Most of that's probably the battery.
yeah, actually.
And then, so what is your guys' goal use case? Because this seems like it'd be really good for maybe like a search and rescue kind of a thing, or is it like helicopter EMS, ground EMS? Do you guys have anything
All the
specific?
above. I mean, anything where you have size restrictions, weight restrictions, especially air, like rotary wing, every pound plays a role into your time, your loiter time to target, fuel, everything. So, I mean, if this is lighter than what they're currently using, and you shave off even a pound, that's an extra 10 minutes in the air. So it could really any application. Our main one initially was for ground medics, that military side search and rescue, who they're like, cool, like I got to dismount from my vehicle and I'm hiking 10 miles to get to this person.
Yeah.
And I don't have a vehicle. Then what's small, compact, you can still carry this blood. If something happens and you're stuck out there for longer than you're expected, like we all saw Black Hawk Down, you never plan to be out there for 3 days, but stuff happens.
Yeah.
And so knowing that, I have that blood with me, it's still good. Worst case scenario, I throw another DeWalt battery on there and I can extend that out by another 2 days.
Yeah.
Yeah.
That's cool.
I do like that.
Yeah, that's kind of what I had for us to talk about. I don't know, like, you guys have anything else you want to add, or anything else you want to talk about with your product that you think is pretty cool to get out there?
Nothing really that comes to mind. We're still doing, testing. We just did some testing with Special Operations Command a few weeks ago.
Cool.
And that went great. Still waiting on the feedback from them. The government moves really slow. But yeah, best thing, I just found out we're not a FDA regulated device. We're Class 2 exempt. So as soon
Probably
as
saves a lot of time and money for you.
a lot of time and money,
Yeah.
but it also allows us to get this out to market quicker.
Cool.
Yeah.
So there's a big push right now for civilian EMS agencies to be carrying blood, and we hope to be able to kind of sneak in there and have a better solution than what's currently out there.
What's your? Oh, no, you have a question?
I was just, is it, okay, this is just kind of a controversial topic in general, but is that a goal to get approval through the FDA?
No, we don't have to do that.
You just don't have to, period?
Nope,
That's
we
awesome.
have to register the product with the FDA. We pay them their like $7,000 bribery fee, and then they go, cool, congrats, you can now sell your medical device.
Awesome. All right.
So
Yeah.
Are you going to be including like trainings and stuff with that when you start pushing it?
yes, that's the goal.
Long goal.
It's kind of going to depend on obviously we train on how to use the device that we'll do, which is pretty simple. Unscrew the top, put the blood in, screw it in, and
Put the battery on?
pop the battery out as it gets low.
Yeah.
But yeah, ideally I'd like to be able to start kind of doing some trainings with administering blood in the field. We can help these agencies build up those protocols. I know like Ada County's looking at it right now. They're trying to get the kind of constraints put in before they start looking at the logistics of things. I've been working with them a little bit and through St. Luke's to kind of help push that forward and get blood out there.
Nice. That's cool. That's exciting. We just missed out, Chris. Just missed
Well,
it.
I've been out for like 3 years, but nobody just missed out.
Still.
We're on
counting.
the outside looking, and we're peeking through the window.
Ada County's still, I'd say, at least a year out before they actually start putting blood on ambulances.
That would even surprise me.
Yeah.
Yeah. Like just the way it operates. Yeah.
Yeah, and that's just going to be any EMS system.
Any EMS system.
It's going to take a little while, right? So for people that are interested about your product, what's your product called? Is there like a website they can go check out?
Lifehold, the website sucks. We're still very secretive as to what we're doing. We're in the process of redoing that. But you can reach out to me directly. They have my information.
Yeah, we can put contact information or email or something in the description if you're good with that.
I'm good with that.
Yeah.
Reach out. Help you guys. More than happy to if I don't have the answers, I can probably find someone that does have the answers and, help you guys get blood into your agencies. And my device may not be the best fit for you guys. And I understand that. But I can, I know a lot of the companies out there, their devices that they have. So I'm more than happy to kind of help you guys find one that will actually fit your agency needs.
Cool.
Yeah, and even if your device is not for a specific agency, these conversations are crucial, right?
Yeah.
All of these studies coming out, they're all pointing, almost all of them are pointing at the same thing. We need to start having more conversations about blood. There does seem to be a significant benefit to it.
Mm-hmm. Yeah, that was the meta-analysis pretty much points to that, everything that I could look at. So, wholly agreed. And it's such a new thing, right? It's such a new thing that, like you said, these conversations need to be like, I didn't know anything about it, right? Like Wade and I, being ground medics that have never I've just been reading studies this past couple of days and trying to at least have a little bit of knowledge coming in here, not sound too dumb. Like, talking to you guys about it. So, and at the end of the day, regardless, we're just here to help people, right? And so whether that be with product development and getting more blood to more people logistically better, or learning more and educating people, it's what we're here for. Right. To, make sure that people can live, right? Like, save lives out there with this blood. It's actually life. People say, like, paramedics save lives. Blood saves lives.
Yeah, but
for sure.
EMTs save paramedics.
That's true. That's true. Are you trying to start another fight, Casey?
Dude, it's just a controversial day. Like
Man, I guess so.
Hey, I was always told the BLS is what, actually save lives. Paramedics don't do anything.
It's very true. As a paramedic, that is very true.
Yeah. I don't want to talk. No comment.
Any closing thoughts or comments from you guys?
Yeah, I mean, having these conversations, whether it just be us here or you with your medical directors, your agencies, and your hospitals, even community states, like driving this. And it's so new civilian side. Like, we'll see as we continue to go further down this, path, it'll become more and more common. Eventually it'll be, like tourniquets. Yeah. Like, blood's kind of the hot topic. Like, do we not? Maybe not. And like, now I've yet to see any police officer walking around without a tourniquet on. Right. Like, now it's super common. Yeah. It's no longer like, oh yeah, I put a tourniquet on, you're going to lose a leg. It's only been on for 30 seconds, but that leg's gone. Yeah. So, I think
seems to be medicine in general, right? Yeah. Leave-em-fed did the same thing. They call it leave 'em dead. But now it's a standard part of every kid out there almost.
So I think it'll become more and more common as the time comes. I mean, Rattler Medical, we're not the entire solution. Hope to be part of that solution to help guide that and push that discussion forward and increase those capabilities. But it's going to be a long road. There's no overnight Band-Aid like, oh yeah, here we go. Now everyone uses blood. Congratulations. So
cool. Right on. Appreciate you guys being here. Thanks so much for the expertise. Hopefully this is a good conversation started for people, or a good start of the knowledge for people that don't know anything about blood. Especially, we have a lot of EMTs and stuff that listen to the podcast, that this will be their first kind of introduction to it probably. So thanks for watching. Thanks for listening, whatever you're doing. We'll be putting this on both channels. But if you haven't gone over to the Basically EMS channel, if you go to the Summit Healthcare Education YouTube page, the main page, there's a link there. I know it's been kind of hard to find in YouTube searches, but you can find it there if you want to go. Link up there and subscribe over there. If you guys have any questions, I'm sure we could shoot them to these guys over here and try to answer back in comments if you guys have questions or anything. And we'll put your contact information there for sure, so people can reach out to you. But
if you started any debates because of Casey, leave it in the comments.
Yeah. If you and your partner got in any fights because of what Casey said, please let us know so we can share it with Casey.
Conversations are important.
Thanks for being here, guys. Thanks for listening, and we'll check you guys on the next one.
Thanks, guys.
Appreciate it.